A very good afternoon to all of you. At the outset, I would like to thank Laila Madam for giving me such an opportunity to speak amongst such august speakers. So today I'll be talking about one of the emergencies in ophthalmology. You can see the images of two children in this with almost similar presentation, but the focus today would be on orbital cellulitis in children. This is one of the most common causes of acute proptosis in children. I'll be taking you through this today. So what is orbital cellulitis basically? It is the infection. It's an infective process involving the lid and the orbital tissues. The simple structure here, which is a fibrous septum, it separates the lid and from the orbital tissues. So based on this, broadly we can classify it into a preseptal cellulitis and orbital cellulitis. In order to understand the disease better, we need to know that most often, especially in children, it is a contiguous spread of infection from the adjacent ethmoid and the maxillary sinuses. So the reason being the presence of a thin walled lamina papricia, which separates the sinus and the orbit. You have valvulus orbital veins from the sinuses to the orbits which carry the toxins, and also anterior and posterior ethmoidal foramina which behave as conduits. Apart from this, you also have infections arising from the dental caries or other foci of infection elsewhere, leading to a hematogenous spread and presenting as orbital cellulitis. And often trauma is also seen to disrupt the orbital tissues, leading to an infection of the same. So the spectra of microorganisms are usually the gram-positive cocci, which are Staphylococcus species and streptococci. Earlier, Haemophilus influenza used to be a common pathogen, but with the advent of Haemophilus vaccination for children, now we have seen a decrease in these organisms. But one needs to be cautioned because this is known to cause meningitis, so we need to treat this and follow them up closely. A rarer entity would be a herpes simplex virus infection or mycotic infections. Like we saw earlier, there would be an infection from adjacent structures, history of trauma could be there, surgeries could be there. Usually the mother would or the parent would say that there is a sudden onset of painful prominence and swelling of the eyelids. Children most often would not notice double vision or defective vision, but older children would talk of the same. And if the child is found to be drowsy or has a fever or sudden visual loss, then it's an indication that it is probably progressing. On clinical examination, you have the classic signs of inflammation, which are rubor, calor, dolor, and tumor. And as it progresses into the orbital tissues, there will be an impaired visual acuity. You will start to see RAPD, that is indicating that the optic nerve is at compromise. Ocular movement restriction will be noted. There will be a proptosis, and due to the raised intraorbital pressure, often you can record very high IOPs. So if you are to see dystopia in a child or displacement of the globe, that means there is a probable accumulation of mucopurulent discharge there. And any overlying skin involvement in the, could be seen in necrotizing fasciitis or mucormycosis. And if there is exposure, definitely there would be corneal epithelial breakdown. Vision losses have been reported in cases of orbital cellulitis, which could be due to CRA or a central retinal artery occlusion. Numerous classifications are there, of which our favorite one is the Chandler's classification of orbital complications in acute sinusitis. Like we saw earlier, preseptal cellulitis, which means the infection of the anterior lamellar structures, which is the skin and the subcutaneous tissue, whereby the child on top has just a preseptal cellulitis. The child beneath has a lid abscess, which was located only predominantly in the preseptal region, and the child improved with an incision and drainage. So orbital cellulitis, this is when the orbital structures are involved. And here on doing a CT scan, you will be able to see that there is inflammation and edema of the orbital structures, such as the extraocular muscles, and you can also note an optic nerve compression in very severe cases. A subariosteal abscess. So this is the collection of mucopurulent collection between the periosteum and the orbit. It need not always be an abscess. There is also an entity called subperiosteal effusion, whereby there is just inflammation beneath the periosteum, and this will be treated once you treat the infection per se with antibiotics. Orbital abscess and cavernous sinus thrombosis is a very severe form, which since most of us work in purely eye setups, you may not come across this very easily because the children would be drowsy and they will be needing systemic care and stabilization. Role of imaging cannot be overemphasized, especially doing CT orbits, because it is a quick way of doing imaging in children. It helps image the orbit and the sinuses simultaneously, also talking to us about the bony integrity, and you can also locate the abscess. MRI orbit, due to the difficulty of performing this in children, you usually reserve it for cases where you're suspecting an optic nerve compromise or a suspected brain abscess or cavernous sinus thrombosis or a vegetative foreign body or a fungal infection. So as ophthalmologists, we need to know both about the ocular as well as the systemic complication. Here are a few, and you can also note that it can result ultimately in blindness. Similarly, this infection can progress to an orbital abscess, and due to the proximity of the brain, it can lead to a brain abscess, and ultimately it can even result in death. As a routine, it's best to send for a complete blood workup along with ESR and blood cultures. Also, if you have an external source of injury and there is pus, you can send that also for culture and sensitivity. Renal function test, because we would be starting these patients on IV or oral antibiotics, and renal clearance needs to be good. I personally like to do liver function tests and glycemic levels also to have an idea as to if we have any undetected diseases. CRP is per se not for diagnosing, it's just to look for the improvement or progression of the disease. So coming to the management part, preseptal cellulitis, pretty much easy. You can give oral antibiotics and anti-inflammatory drugs on an outpatient basis, but beware, you need to always have children under close follow-up, because there are cases where the child can progress very quickly, or they will require admission, especially in those who appear toxic or with a known H influenza infection, or who are starting to worsen, or they do not show any signs of improving. Orbital cellulitis, without thinking, you have to always admit the patient. You have to send for the blood workup, as we saw earlier. Broad spectrum IV antibiotics are started, and these can be modified eventually based on the blood culture and sensitivity patterns. You need to rope in a pediatric infectious disease specialist. ENT consultation is not mandatory, but in children, since the most common cause is sinusitis, it's always better to get their opinion too. Vision, pupil and EOM monitoring, every 4th hourly strict monitoring is required, and you can also add topical antibiotics of your choice. So being ophthalmologists, we are a little far removed from our general practice of giving antibiotics, so we are always in a fix as to what antibiotic we need to start first. So since we are dealing with a gram-positive spectrum predominantly, broad spectrum penicillins and 3rd generation cephalosporins are preferred. And in this, if you have a case of orbital cellulitis, IV antibiotics for a minimum of 48 to 72 hours is required, during which you will also look for improvement. So if you see that there isn't necessary improvement, that means there could be probably an anaerobic infection also, and you can add drugs such as metronidazole, tinidazole, and also clindamycin. MRSA coverage is given in cases which are likely developing an orbital abscess or going in for cavernous sinus thrombosis. But the treatment does not stop with just IV antibiotics for 48 to 72 hours. Even if the patient is being discharged, the child needs to be on antibiotics, oral antibiotics, for at least 7 to 10 days. So this is a debate whether you need to give corticosteroids or not. So if you note the term cellulitis, itis means inflammation. So by giving antibiotics, you're basically covering only the infective process, but there is an inflammatory component also, which can increase the hospital admission time, and it also can lead to other morbidities or complications. So we regularly, the ENT specialist regularly gives corticosteroids for sinusitis, which shows that there will definitely be an improvement. In a review article by Liu et al., CRP was seen as a potential marker for standardization of steroid therapy. There is no standardized protocol as to how much to give, but in my practice, what I would like to give is, while the child is improving, after 48 hours, you can give IV steroids, and look for improvement, and thereby discharge the child on oral steroids in a quick tapering dosage with 1 milligram per kilogram. And surgical indications are obviously when the patient fails to improve and when you can locate orbital abscess. Necrotizing fasciitis, you have to look for progressive skin ulcerations, and this can quickly progress to systemic toxicity, so prompt referral and treatment is required. So we were talking about subperiosteal abscess. Not all cases require drainage. So in patients who are 9 years and above, who have large size of SPA, non-medially or located ones, recurrent SPA or associated chronic sinusitis and anaerobic infections or dental infections, you need to go in for a surgical treatment. So mycotic orbital cellulitis is rare. It's mostly seen in immunocompromised patients. And a few masqueraders here. So this is a child who has who presented with a similar picture, but it turned out to be a case of orbital inflammatory disease, which is almost similar to this. This was a child of thyroid eye disease. It's a bilateral presentation, but it can also be unilateral. This particular child had a lymphangioma into which there was an acute bleed. He did well with bleomycin intralesionally and drainage. And this was a case where a child had a recurrent orbital cellulitis picture, basically due to a ruptured dermoid cyst. And also you can see it in malignancies such as rhabdomyosarcoma and retinoblastoma involving the orbits. So I would like to end on this note. Do not take any periocular infections in children lightly, because just like how they bring home very bad upper respiratory infections, similarly the lid infections also can turn to be fatal, leading to orbital cellulitis. Thank you.
Thank you, Dr. Anju, for that wonderful coverage of orbital